opaque, radius, in CT,
hyperechoic and hypoechoic.
hyperechoic,
USG, then USG.
USG.
hyperdense,
Contrast,
Hypodense,
non-contrast in CT.
MRI, I already told you, no?
CT contrast and non-contrast.
MRI
MRI intensity.
Intensity and
High intensity, low intensity.
CT contrast and non-contrast.
Hyperintense, hypointense. Okay.
CCT.
So now, why do we take an X-ray? So what we have to see in an X-ray first? X-ray mainly contains of 4 components. One is first rotation. So suppose rotation, whether the X-ray rotation is normal or abnormal. I am standing here. My projection of rays is that this one, this monitor. So this is the X-ray machine. So this X-ray machine projects rays from this is my anterior position. This is my posterior position, right? This is anterior. This is posterior only now. So if X-ray projections are towards my anterior surface and going to back to my posterior surface, this is ABM. If reverse, if from this monitor is my projection of rays, X-rays. If it is from PA, okay, clear between AP and PA. This based on projection of rays. Okay. So now how to rotation? One thing is rotation. One more inspiration. RIPE. Remember. RIP, rotation, inspiration, projection of rays, and E is expiration. How to interpret between an inspiratory X-ray and an expiratory X-ray.
यहाँ पे तुम लोग 2 बैच कर
हाँ,
रहे हो।
दो
होने के बाद एक बैच आ जाना, ठीक है?
So rotation, inspiration, projection, and E. So we have completed P, projection of rays, either anterior posterior direction or posterior anterior direction. Now we will come to rotation. So suppose my rays are coming from anterior posterior direction and I am rotating like this. So my lateral view will be exposed more, and this view will be, this medial view will be. So can I interpret an X-ray correctly?
No.
Okay, only this capillary blade will be seen and this clavicular will be seen because only this area is exposed more. Okay, so rotation of an important rotation is important for an X-ray. So for rotation, I have to see my both medial ends of clavicular aligning towards my sternal axis, or 2 spinous causes are same, projecting towards the same or not. If it is rotating like this or if it is rotating like this, the X-ray is taken wrong. Okay. So now how to one thing is anterior posterior view, posterior anterior. How to tell that it is an anterior posterior view and a posterior anterior view. This is very important. So in the anterior posterior view, when my chest X-ray projection of beams are directly to my chest cavity, I can see only anterior ribs, mainly anterior ribs in anterior posterior view. In a posterior or anterior view, you will be seeing only posterior ribs. Everything is written in that, you don't need to write. Okay? Everything is written, all the differences, everything is written. Clear? Okay? And one more thing is anterior views, anterior ribs are clearly seen in AP view. Posterior ribs are clearly seen in posterior view. Okay? Now one more thing is your clavicle is above field or below field. Clavicles are both above the lungs or below the lungs. That you will interpret in the next X-ray. Next, when I am taking this, when I am to my shoulder, my view of scapula will be present in an AP view. When I am standing in a posterior or anterior view, my scapula will be outstretched. Why will be outstretched? It will go. I am extending my arms towards the outside the outstretched hand, such that my scapular blades will be going out, such that my lung fields will be clear, such that there is no obstruction to my lung field. Okay. So for any respiratory X-ray, which now by this point of scapular shadow only, now for any respiratory X-ray we will be going for PA. Why we will choose PA? Because there is no scapular obstruction. Suppose now there is suppose the patient is bedridden, or patient is ICU, or patient is non-cooperative, patient is intubated. Then patient can't stand, then we have to go for AP. So what are the indications also there? Okay. If suppose I can't take a PA, what are the conditions where I can't take a PA? Okay. Now whether the X-ray is inspiratory X-ray or whether the X-ray is expiratory X-ray. Okay. How to differentiate?
Depending on the diaphragm.
Depending upon one thing is depending upon diaphragmatic shadow and one thing is ribs count. So normally when we will take an X-ray in an inspiration phase or in an expiration phase.
Expiration.
So suppose you have a balloon. So you want to know the capacity of the balloon. So,
Inspiration.
So when you will say it has maximum capacity, but when it inflates to its maximum. So I can see the pathology or any, suppose if it has minute holes also, I can see when I inflate it completely or because when I inflate it completely, if there is any hole or any function in the balloon, the air escapes and I can point out that point. So if I take in an X-ray with a small air in that, I can't tell exact pathology of the lung. So always the X-rays they will be taken in an inspiration. So normally in an anterior view of an X-ray, it should contain minimum of 7 to 8 ribs. In the anterior posture, 7 to in the AP view, 7 to 8 anterior ribs should be seen. The posterior minimum 9. And the parallel, if suppose if it is there are more than 9 ribs, if there are more than 9 ribs, then what is the condition? If there is more than 9 ribs, greater than 9 ribs in a posterior anterior view X-ray,
And
there is what does it mean? There is more amount of
yeah,
air in the lungs. So it may be hyperinflated X-ray. Hyperinflation. Inflation is normal. Hyperinflation is more amount of air in the lungs. What are the causes of hyperinflation first? What is the pathology?
Pneumothorax.
One is pneumothorax, one more bronchiolitis. Where the air can't escape. Air can go inside, but air
not
can't escape out. Such that air stays within the alveoli. Clear? These are the differences between. And one more thing is, in my hyperinflated lung, there will be the ribs position also will increase. Normal ribs, if it is present, the parallel ribs, the position will also increase because the volume of the lung increases, the ribs also stretches up. Clear? So, if you see will come from that, what we can see in a chest X-ray, PAV or APV, we can see a trachea placed centrally and slightly towards the right side. Okay, slightly towards right side, not grossly towards right. Slightly, it can be central or slightly towards the right side. Then after trachea, we'll come for the what we can see, the aortic knuckle. This is the trachea, the aortic knuckle. Then we'll come for the heart shadow of left ventricle. Then we'll come for right atrium, the superior vena cava from down, inferior vena cava. These are my diaphragmatic shadows. This is my liver. This is my stomach with gas shadow. Fundic gas shadow. Clear? These are two lungs.
Superior vena cava once.
This one. Towards this side is, towards my right side is superior vena cava. Towards left side is aortic knuckle. And these are bronchopulmonary vessels or markings. These two are two clavicular ends. Should light always towards the medial end of my medial end. Now, what is the differential between the radio opaque and radio lucent? So, radio lucent is black, radio opaque is white. What pathologies can you see radio opaque?
pneumonia, in case of pneumonia.
Any patch,
Any
any
patch.
consolidation, any mass, any effusion. Okay? Any patch, any consolidation, any mass, any effusion. Okay? Effusion, pleural effusion. Anyway. So air black, hyperinflation. Okay? And there are two types of lesions we know. Pushing lesions, pushing lesions and pulling lesions. I am pulling him towards me. Pulling. So all the pulling lesions, they'll take the trachea towards it, towards the same side. The pathology is towards right side, the lesion will pull towards the right side. If I push towards the opposite side, all the lesions of like mass or pleural effusion, all they will push towards the opposite side. What about pneumonia?
In case of pneumonia, there is same side.
Same side, not same side.
Medially
No shift,
No
deviation.
No deviation.
In pneumonia, it is central. Clear?
So in case of pneumonia, if pleural effusion is
another condition.
Pneumonia with, I'm asking about only pneumonia with pleural effusion, effusion is a pushing lesion. It will push towards the opposite side. Now see, this is the same person's expiratory view and an inspiratory.
Inspiratory.
Now you can clearly see. Expiratory view and an inspiratory view. Clear? PA view and AP view. Can you see the scapular blade in a PA view?
Yes.
Just observe it.
Yes.
Can you see scapular blade in a PA view?
Scapular blade. No.
That's only the main difference, no? That's what I'm asking. This is the scapular blade. Can you see here?
No.
See my clavicles also in a PA view, in an AP view.
अभी सामने की तरफ.
Above, below. Clear? Clear. So, but normally, if we have AP view only, we can compare PA view. But for remembrance, like clavicles below lung strings, here above lung strings. Slightly, not cross. Okay. Main thing is scapular blade, scapular shaft. Clear? Okay, all the 4 points covered. Please check.
Until your heart will be relatively enlarged.
So, in my anterior view, the rays of projections are by heart side. I forgot about heart size. Anterior view, my rays of projection are directly towards my chest. Chest from anterior ribs. Immediately after anterior ribs, what is laying?
No.
Heart.
In this picture,
Anterior.
Oh,
Heart.
यहाँ पे सामने.
So, rates of absorption more towards the heart. So, in my AP view, slightly the heart size is increased. In my PA view, directly posterior ribs, then immediately there is no heart. Immediately lungs are present. So, for clear now. That's why the heart of size, it is not cardiomegaly. Slightly raised, slightly increased heart size. Okay? Now start diagnosis.
Massive
What
console.
to diagnose in what we have to tell in an X-ray normally? X-ray, diagram. Please look at that diagram. Of AP or PA view, normally generally we take all the respirator is X-ray view of PA view. So what is the pathology in that? Left-sided pleural effusion. And shifting my trachea, all the things towards the
Right
opposite
side.
right side. Main thing is pathology is complete right side, left-sided. So consider this is as left, this is as right, or based on.
Left.
So this side,
Left.
left-sided pleural effusion. Clear? So in pleural effusion, what is the important thing we want to know?
CP and
CP and
Postophrenic. Postophrenic means right. So angle between diaphragm and ribs.
Disappear.
So it is normally it is sharp. But in any case of pleural effusion, angle is
Blunt.
okay. In pleural effusion, now if a X-ray is of pleural effusion, first you have to see all the radiolucent radio opaque substance. Then you have to see position of trachea, whether it is shifted to opposite side. Next, one more thing you have to see is CP angle. Clear? See it clearly. Blue extracardia. I didn't keep for the extracardia.
হাতটা এদিকে
One more thing you see in that. What is the difference between right lung and left lung?
Left lung is more.
Pneumothorax type.
So those areas
Count the rays. So it's looking more black. More black means more
air.
means
Pneumothorax.
don't tell directly.
Inflated.
Hyperinflated.
Left side is hyperinflated.
Hyperinflation.
Directly don't go for diagnosis. Okay? Hyperinflated.
More
Probably pneumothorax. Probably we can't know the history because we are not having. So it can be bronchiolitis also. Then your accident, if you tell directly pneumothorax, then your accident will ask, why can't it be bronchiolitis? What will you say? Probably hyperinflated. What are the causes? Now we'll go into the cause. You can say bronchiolitis. It may be bronchiolitis or it may be pneumothorax. Always directly, if you tell the diagnosis, they will go into the diagnosis only. If you say hyperinflated, then we will come to next question is you have to minimize your questions. If you say diagnosis, then he will ask about pneumothorax. Now tell what are the causes of pneumothorax. Suppose you are alone in an airport. Suddenly a patient falls down, and you diagnose as pneumothorax. Now what will you do? You don't have ICD. Normally we will plan for ICD only, no? Intercostal drainage at fourth intercostal space, mid-axillary line. So now, now they'll ask you, now if you are not having any ICD, then what will you do? What will you do?
Immediate shift to.
I see.
From airport to hospital, how much they suppose? Now here all the airports are far away only. at that place, at that situation, what
Sir,
you do.
sir,
Second
ये
intercostal space,
intercostal space directly in-
intercostal
हाँ थोड़ा को सेंटर से
So then they'll go second intercostal space directly. In many of the movies also
Safety.
we suddenly fall. So we, in order to reduce the pressure within the intrapleural pressure, immediately we'll prick within a blade and we'll do it in the second intercostal space. Clear?
Sir, how to count rib?
How to count ribs? Good question. So now this is a PAV. Consider this as PAV. So when will you say it is hyperinflated lung?
Best,
More than 9.
More than 9.
So start from here. These are PAVs. 1, 2, 3, 4, 5, 6, 7, 8, 9. Slightly this one. 10. It's not gross hyperinflated. It's a hyperinflated. More than 9. Okay. And see the now normally I told you normally in a normal lung you see here we will be having parallel lips of anterior and posterior. Can you see here parallel? There is parallel. All my ribs are see here. This is my posterior rib and parallelly we have one more anterior rib. But here can you see this parallelness? It's going on in a hyperinflated lung. Okay. Clear? See here, immediately one rib is here, one rib back side. You can see it clearly. Here one rib is back side. But here, the parallelity of ribs here. See here. Now here. But here you can see the posterior rib. The parallelness of the ribs will also be decreased. Then hyperinflated lung. Normal lung, so you can see. Now see here, this is normal lung. See the parallel of anterior and posterior rib. And this, now see, observe, now just imagine the hyperinflated X-ray. Now see this X-ray between anterior and posterior rib. This is my anterior rib, this is my posterior rib, and this is my anterior rib, back side. If it is posterior, then that will come towards my anterior rib, the space. Clear? Now just assume this and assume this. Clear?
हाँ बे
Okay.
चेंज है
Now this.
डेक्स्ट्रोकार्डिया
fluid level.
Your extracardiac.
नहीं सर पहला वाला था
Sir, fluid US
I give one extracardiac.
fluid level.
एयर फ्लूइड लेवल
Fluid level.
Air, there is air,
Air
there is
fluid.
fluid. Then what is that term? If air through. Air, new.
हाइड्रोथोरा
Clear? Next one.
एयर फ्लूइड
Repress next. No? Answer is there?
Lower patch.
Answer is there?
Lower patch.
What are the causes of lobar patch?
ट्यूब टीबी
Tuberculosis. So there is a radiolucent substance present in my left lower lobe or any lobe. I'm considering it as middle lobe, no?
राइट
Right.
Right middle lobe.
राइट मिडिल
Right middle lobe. So there is a rodeo X-ray of radiogram taken in a posterior anterior view showing a consolidation as a radio opaque patch in my right middle lobe. Probably
इसको भी
a consolidation caused due to a lobar patch or consolidation caused due. They ask them caused due to what are the causes? TB, pneumonia, fungal
ball.
What do you call in a fungal origin?
Aspergillus. Fungal ball.
Fungal culture was positive for this case. The Trishankar. Fungal yeast budding cells was positive. So aspergilloma. Fungal ball.
फंगल
Fungal ball. So the air cavity is surrounded by all the microorganisms.
तो ये हेगी का
That answer is there. It is.
Cavity.
So what are the causes of cavity? Same.
TB,
Fungal
ball.
Aspergillosis also. Aspergilloma.
Yeah,
It's already
shown.
in the spotter I told you. Okay? What you are seeing mainly ET tube, endotracheal tube, baby is intubated. This tube is the ET tube.
राइट साइड है
By seeing this one, ET tube only, no? Metastasis. Why you? I can say it is a patch. Multiple patches, multiple TB cavities. I say. How do you defend this? Now defend me. As an example, now you have seen. I can tell you now. Suppose he told metastasis, because answer is there. Or okay, I told that is a metastasis. Then he told me. The externalist he is asking me why it is metastasis can't be treated with multiple patches of any consolidation, multiple patches.
So the
Cannot
patches
say-
are so the
It can be a-
Calcification.
It can be a multiple patches.
so the patches are also in the mediastinum region.
Excellent. The patches are also in the mediastinum and liver lobes are also involved. And you see the patches in my liver also. Excellent. So metastasis. So what are the probable causes of metastasis? RCC, testicular carcinoma. First is, if suppose the baby is 14-year-old child, then testicular carcinoma.
Ovarian carcinoma.
Ovarian carcinoma also in female. Baby, so boy is 14-year-old child, the carcinoma of testis, carcinoma of pelvis is the first cause. Then RCC, then ovarian. Any cancer can cause metastasis. It can be a skin cancer, it can be any cancer. It causes metastasis. What is this?
Steeple sign.
The answer is written. Steeple sign. So steeple sign, what do you mean by steeple sign?
Pencil tip
మన
sign.
పెన్సిల్ టిప్
Sign or dome shape sign. Like this one. Can you see clearly this shape? Yes, in my X-ray. Dome shape sign. Can you see?
నా
Where? Show
గ్రూప్
me.
గ్రూప్
Show me. Dome shaped sign. So acute, 5 minutes. Okay. So acute epiglottitis, right? See, croup. Acute laryngotracheobronchiolitis. Is this an emergency condition?
ఎస్ నో సార్
No.
నో సార్
No. Acute tracheolaryngitis, not
Laryngo-
that emergency condition. Acute
Epiglottitis.
laryngotracheobronchitis, it is inflammation of larynx, bronchia and trachea. So what is the primary cause for this for croup? What is the primary cause?
బ్యాక్టీరియా
Epiglottitis.
నా బ్యాక్టీరియల్
Wrong. Viral origin. Croup is always a viral origin. Go and see viral influenza. RSV, respiratory syncytial virus, then para-influenza virus, any adenovirus, all the viruses. So it is viral origin. Role of antibiotics.
No role of
No.
Viral cause.
Suppose if the fever still persisting more than 7 days and symptoms are still persisting more than 7 days, because viral will always be sudden origin,
Sudden origin.
and acute sudden origin and short
Acute
duration of
origin.
time. Not like TB, because how to remember this? TB or any bacterial diseases will give for antibiotics minimum 14 days, and suppose this fever is not subsiding, symptoms are not subsiding, still we have to continue the antibiotics. Then it may be more than 7 weeks of duration. Then we have to role of antibiotics. In the initial period of infection, no role of antibiotics in any viral fever. Okay. So what is the treatment for this? Symptomatic management.
Oxygenation.
Okay, so there is saturation fall, or if there are any features of nasal flaring, if there are any features of chest interaction, if there are any features of nasal flaring, chest interactions, or abdominal, normal respiration is thoraco-abdominal, right? If there is any abdominothoracic or use of any accessory muscles for respiration, then you will continue with oxygen. So
Acute
this is
epiglottitis.
acute
Touch
epiglottitis.
emergency.
E for E. E for emergency. Acute epiglottitis is emergency. Remember like this. E for E. Emergency E. So what is the important cause for this?
Any bacterial.
Any group B streptococcus.
Group B streptococcus.
Group B streptococcus is a major pathogen for this. Remaining next falls the other. Klebsiella, Klebsiella, remaining Klebsiella or any organism. Staph, Streptococcus, Klebsiella, Listeromonocytogenes. Okay. Next.
CT.
Cardiothoracic ratio. How to calculate? Anyone who can tell me?
सर
Heart ratio or thoracic?
Thoracic ratio.
More calculate heart ratio. Either keep a pencil or a pen. Okay. In my trachea, from there count to my right shadow. Then from right shadow to middle. From this pencil to medial side. Lateral side and medial side.
maximum
And
length.
Maximum length. So from now, this is the maximum length, no? Up, this is from and this side this. from here to the up to my pen and from my pen to this shaft. Count that by thoracic. Thoracic to from here to here. Always it will be in plus or minus. It will be in single one digits or in point digits. Why? Why?
What's the question, sir?
My cardiothoracic ratio will be in single digits or in point.
Point.
Always the cardiac ratio is less more than thoracic. That is only the simple answer. Nothing more. Not only that is the simple answer. Because cardiac shadow is less than thoracic shadow. Always it should be less than, it should be in point. So 0.5 is normal. Anything more than 0.5, your heart size will increase. So your C will increase, the thoracic ratio will decrease. So C will increase means always from 0.5 to it increases. No, my cardiac size increases. So the value goes into positive. These are damn sure questions for your meet also.
Snowman.
Figure of 8 appearance. I completed fast instead of 3 hours. Figure of 8 appearance.
Snowman.
Snowmans are TAPUSA. Total anomalous pulmonary venous congestion.
Bootstrap.
Petrology of shaft. There is classically you will be seeing a boot. What are the components of boot shaft? TOF.
Overriding of
Right ventricular hypertrophy, overriding of aorta, pulmonary stenosis,
And
VSD.
VSD.
Ventricular septal. What do you mean by pentology of Fallon?
Surgery.
Log plus ASD. Log plus ASD.
ASD.
Pentology 5. Okay? Clear? I'm a bit triology of Fallon. Without any ASD, ventricular hypertrophy, pulmonary stenosis.
Overriding.
Biology, petrology, pentology. What is the surgery for TOF?
No.
What is the surgery of TOF?
VHD correction fast.
Bloblock something will be there. Bloblock shell. This is over. I told. TAC. So there will be a confusion between EA and TOF.
String on.
This is Egon string appearance, that is
And
boot shaped appearance. There will be a confusion. See, oval shape. Here egg shape. Heart is egg shape. There it is boot shape. Okay.
Only one end is
Slide,
curved.
there should be a knuckle, boot knuckle for top. Here the knuckle is not there. Only oval shape.
stream on it.
This is diaphragmatic hernia. Already I told. Okay. I'll tell for your batch. For this batch I already told. This is record. If this X-ray comes to you, the HOD sir, read complete about vitamin D metabolism and income. Please don't miss that thing. Complete vitamin D metabolism. Other day for this guy sir was asking even the spelling of rickets, I guess.
Yes.
ठीक है